Record. Good evening, everybody. Welcome to this month's Journal Club. It is common knowledge that in terms of colorectal cancer, rectal cancer is considered a separate entity, and neoadjuvant chemo radiation for locally advanced tumors, and even preoperative radiotherapy and neoadjuvant chemotherapy, all of these things have been tried and well established as far as rectal cancer is concerned. And in terms of colorectal cancers, the ones which are inoperable at the time of diagnosis, then you cannot call it neoadjuvant, you can call it anterior chemotherapy. And then after it shows signs of down staging, then you can consider operating. But this is a new vista that has been opened up for operable colon cancers, and this is one of the landmark trial, Foxtrot collaborative group, and this is the I think the mature results of the RCT. I think this is going to change the way we look at things with operable colon cancers. So I think we would be actually happy to have Swaroop whenever he's available to join, because his views, he would have probably known about this Foxtrot trial better than all of us. So without wasting much time, we'll start. Nikitha, go on.
Yes, sir. Thank you, sir. Good evening, everyone. Today's journal club is on the paper of preoperative chemotherapy for operable colon cancer, mature results of an international randomized control trial. It was conducted by Diane Morton et al. And the Foxtrot collaborative group. It was accepted on October 2022 and published in January 2023. It is published in Journal of Clinical Oncology. Impact factor of this journal is 50.7 and the site score being 40. Shimago SJ ranking is 9.3 and H index is 574. Could anyone tell me the difference between the impact?
Yeah, tell us about the impact factor, site score, Shimago SJR and Shimago, whatever the H is. I don't know about the H, what is Shimago H? What is Shimago H, SJR and things, you can tell us.
Sir, if a journal has H number of papers published, number of citations, number of articles having H number of citations is called H index, sir. So it's like prestige of the journal within the prestige of the paper within the journal, sir.
Okay. See, I think we'll need to all go back and have a good look at these things, because I think it is important. Till now, we were relying on something called impact factor. So impact factor, I think, Praveen, will you be able to tell us about impact factor?
Yes, sir. I am audible, sir.
Yeah.
Sir, impact factor is average number of times the journal is cited in years, sir. Previous 2 years.
Average number of?
Average number of citations of a journal in the previous 2 years, sir.
Okay.
Citations of the paper in the journal.
Good evening, Srikanth.
Good evening, sir.
So impact factor used to be the standard that used to be, I think, used. Now the new this one has come, is called site score, and the Shimago. I think Shimago is what is available for public consumption, and its subscription version is the Scopus. So I think Scopus SJR. What is the full form of SJR, ma?
Journal ranking, sir. Shimago journal ranking.
Shimago journal ranking. Yeah. So anything more than 1 is good. Less than 1 is not good or average. Again, I think I just, site score, impact factor, and SJR, they are all kind of same, but I think site score and the SJR rely on much more number of factors. So I think all of you, the homework today is to go back and look at all of these things. Okay. So basically, it means that this Journal of Clinical Oncology is a excellent journal with extremely good number of citations in all and across the published data. So a Journal of Clinical Oncology is a very prestigious journal with a very high impact factor and a very high site score and SJR score. Okay, carry on, ma.
Before going into the introduction, I would like to emphasize the word mature results. Sir, what does it actually portray, sir? Rather than any results of a trial, what does mature results mean specifically?
Is it a question to others or is it a question to me?
It's to you, sir.
Okay. See,
No, who is asking this question with the one presenting?
yeah.
Then why you are asking now? You had a lot of time to ask before.
Sir, I didn't notice it significantly, sir. I googled it up, but I couldn't find proper
No,
meaning
that's
for
what
mature results.
you had posted this 1 week back. From 1 week, what were you doing? Or you wanted everyone to know what is the meaning?
Is anyone else can anyone else come up with the answer for these mature results? Hello, Abdul, Sanya, Vinod.
And if no one knows why no one questioned or all this
Yes.
rest, this thing, Ravishankar or Niranjan. Huh?
See the basically what happens with this, this very standard, probably this is a multi-center randomized control trial. What happens is they will, because the results of these trials are extremely vital, precious, and awaited, because a lot of the future direction of the management of these patients depend on the results of these trials. So they give what is called as initial results. So the initial results will be, for example, even the um, the trial randomized control trial, which looked at to establish the superiority of robotic surgery for anterior resections compared to laparoscopic and open. The initial results were published and then the final results were published. So basically, the mature results means that the follow-up of these patients are longer and all the parameters which are studied in much more careful detail, subgroup analysis made, and finally you come to a conclusion based on the initial research question. So the initial results, for example, let us say at the end of 2 years is very promising. So people, and then for example, you are looking at a drug or a particular surgery to be superior to the other one, and the initial results show that the 30-day mortality and whatever other parameters you are looking at are all good. Then you say, okay, this surgery is as good as the previous surgery. But then you look at the end of 2 years or 5 years, then the results which are there are mature, the data is mature, and you also look at subgroup analysis and everything. And then more, this is usually after the trial recruitment has closed. So no more patients are recruited for the trial. And then you publish the initial results. And finally, after 2 years or 5 years, whenever they are, for example, even the classic trial, initially what happened was the classic trial was the one which established the importance and also the efficacy of laparoscopic surgery in colorectal surgery. There was a lot of skepticism about whether laparoscopic surgery is good enough for colorectal cancers, and they said there is port site recurrences and all of these things. So there was a lot of confusion and lot of negative factors, negative sort of impression about laparoscopic surgery for colon cancer. So the classic trial was brought in, and they published the initial results at the end of 1 year, and they showed that it is equally good. And at that time, there was no evidence of any port site recurrences. But then at the end of 5 years, they showed that even the long-term results of these patients are good. They have not had any recurrency. Other thing is, they said, the laparoscopic surgery is not as precise as open surgery. So all of these things were answered. And at the end of 5 years, the mature results showed that classic trial showed that the laparoscopic surgery is very good and is as good as open surgery for colorectal cancer. So that is the mature results. So I think this is similarly the mature results at the end of a particular period of time, where the initial results have been confirmed. Subgroup analysis have shown that all the initial, what you call the proposition has been proven. So the research question has been answered in the affirmative. So that is what it means by mature results. Okay, carry on. I hope everybody is clear now. Nikita?
Yes, sir.
Okay, carry on.
The purpose of this study was to see the neoadjuvant chemotherapy has potential advantage over standard postoperative chemotherapy and for a locally advanced colon cancer, but requires formal evaluation. So colon cancer is the second most commonest cancer worldwide. 1.7 million diagnoses annually. Standard treatment is surgery followed by adjuvant oxaliplatin fluoropyrimidine chemotherapy for those with moderate to high risk disease. Preoperative and neoadjuvant chemotherapy has substantially improved outcomes in other gastrointestinal cancers. Shrinking tumors before surgery may reduce the risk of incomplete resection and tumor cell shedding during surgery. Neoadjuvant chemotherapy can start many weeks earlier than postoperative adjuvant chemotherapy, so could be more effective in eradicating micrometastasis, particularly as surgery induces growth factor activity, potentially stimulating tumor proliferation before adjuvant chemotherapy started. The key objective of this study was to determine whether giving the first 6 weeks of chemotherapy preoperatively might safely reduce the recurrence risk in patients with locally advanced but operable colon cancer. The methods which are described in the paper are study design being the initial factorial design of 2 into 2, which shows that there are two variables at 2 levels, which are which is used to assign the participants in the ratio of 2:1 to neoadjuvant chemotherapy and adjuvant chemotherapy. Patient with RAS wild tumor also randomly assigned in 1:1 ratio to receive panitumumab or not during the first 6 weeks of chemotherapy. Outcomes which we were aiming for were the primary one was residual or recurrent disease within 2 years from random assignment. Secondary outcome included surgical morbidity, histopathological staging, regression grade, completeness of resection, and cause-specific mortality. Eligibility criteria is defined as biopsy-confirmed colon cancer, CT predicted T3 or 4 with extramural extension, which is greater than 5 mm, which was modified to greater than 1 mm after the pilot phase, and M0, metastasis 0, being fit for both surgery and chemotherapy. Patient with bowel obstruction were eligible if first defunctioned with a stoma. Patients provided with a written informed consent. The methodology was treatment allocations were done by telephone or internet using a minimized random assignment procedure. An independent data monitoring committee reviewed the accumulating data yearly. An internal safety and feasibility pilot was included initially. Surgery was scheduled for 4 to 6 weeks after completing neoadjuvant chemotherapy. Adjuvant chemotherapy was scheduled to start 6 to 10 weeks after the surgery. A follow-up period of a full clinical assessment, including carcinoembryonic antigen and pelvis thorax abdomen CT scan at 2 years after random assignment was mandatory. 6-monthly CEA and yearly abdominal CT were recommended for the first 3 years. Statistical analysis, it was planned that t-test and Mantel-Hansel test for association used SAS 9.4 software. Planned subgroup analysis were of neoadjuvant efficacy by randomization, stratification variables, and by biomarkers potentially predictive of treatment efficacy.
Okay. So go back to the last slide. Sonia,
Yes,
are you
sir.
there?
Yes, sir.
They have said planned subgroup analysis. What do you understand by that?
I'm not sure, sir.
Abdul? Abdul, are you there? Hello? Is Abdul there or not? Nikita, is Abdul there or not?
He has joined, sir, but
Abdul?
It shows, sorry.
Okay. See, Vinod, do you know what planned subgroup analysis is?
No, sir.
See, the problem with a lot of these studies and statistics is that what you do is you say pose a research question and then you see what the null hypothesis is and then you see whether you prove the null hypothesis wrong or whether the null hypothesis is proved correct. So that is how the research is done. So a research question and then what happens is you want to sometimes show, for example, let us say there are cause effect relation between a particular either a carcinogen or a drug, whatever, which causes a particular effect. So you can then do subgroup analysis of patients whom have received that particular, or let us say some comorbidity. Has it got any effect on the final outcome? Diabetes, for example, renal failure, or smoking, whatever, obesity. So if you have these any particular cause effect relation or any particular subgroup which are doing better or worse compared to the others in the group, then you do what is called a subgroup analysis. But then this subgroup analysis have to be planned in the protocol upfront. If you don't do that, then what happens is, let us say you are trying to set a hypothesis and then you are not been able to prove the hypothesis. You then resort to subgroup analysis to show, oh, this particular subgroup actually did well compared to the other group. So then you say that your study is still very good. But you are cheating at that time, because if you are doing what is called, these are classified under post hoc analysis. That means you have initially tried to prove something which you have not been able to prove. Then you are finding newer subgroups and newer questions and answering it to say, we have actually proven that this particular drug is good, or this particular operation is better, or this chemotherapy works. And so in this particular, in the renal failure group or whatever. So if you do this subgroup analysis and as an afterthought later, then you have to question the veracity of the data. But if they have planned subgroup analysis, which means they've already in the protocol, they have written what are the subgroups and they have tried to study them, then it is allowed, because they are trying to show maybe a cause effect relation, or maybe a particular subgroups are more affected in this rather than the others. So a planned subgroup analysis is acceptable, but a post hoc analysis is dubious. You don't know whether you can believe the results or not. So that is the benefit of this. So statistics is, as you know, can be manipulated whichever way you want, which is why if somebody is, everything should be included in the protocol. So writing a protocol should be absolutely, foolproof and with a lot of commitment, and also there should be no doubts or questions raised about the protocol itself. So that is why the most important document in any study is the protocol. Okay, carry on.
So critique for the paper after
Vinod,
the methodology.
critique of the paper so far.
Sir, it's a most recent paper, sir.
Good.
And most common cases like colon cancers.
Correct.
So really went. So and the study population is very large. 600, 800, 900 total of. And they have clearly mentioned what the patients they are including.
Correct.
And
inclusion exclusion criteria is one. Okay.
And it's a randomized trial, sir.
Randomized control trial. Good.
Cons, they didn't mention about the doctors and number of hospitals there where they have included the patients from there.
But why do you need to know that?
Because if a surgeon is well efficient, then the clearance will be automatically clear.
See what happens is these are very high quality studies. So they are not going to recruit some, I think there will be
mostly from tertiary centers.
And what happens is all of these people are trained, they are mentored into doing these things. And so the quality is, to be expected to be of very good quality. So you don't have to worry about that. But you are right to questioning that. See, the thing is, multi-central trials have to be much more rigid about the protocols. There should be local monitoring committee, and then there should be a central monitoring committee also, which can make emergency or unplanned visits to check the data and make sure. So there should be a local data manager, and then there is central data manager, and those should have regular interactions so that the data is entered correctly, the protocol is followed to the T. So, and monitoring committee should be there. So multi-central trials are much more difficult, but then you can't have one center doing 700 or 900 operations. So you need multi-centers to do that. So to actually prove something, sometimes, as you said, it's a common condition. So whenever the condition is common, to prove the difference between the two groups, you need larger numbers. When the condition is not so common, you don't need so many numbers. Okay. So that is why multi-central trial is not a negative in certain situations. Okay, carry on.
How many years they have followed up?
She'll come to that.
Okay.
Nikita, Praveen, do you want to add anything? Are there any cons? Are there any negatives?
No, sir, everything, sir.
Okay, carry on. Nikita.
Yes, sir. Sir, in the methodology, they did not mention about the either the study population or the number of years they are supposed to follow. In the results, they clearly described everything, but should they particularly mention in the methodology of a paper about the?
They should
Yes,
have. They should have.
And there was no exclusion criteria, sir.
Exclusion criteria, they have not written it, but they have said,
Yes.
Operable locally advanced operable colorectal cancers, which means you have excluded non-operable ones. Very simple. You don't have to state it. It's obvious.
Okay, sir. And study period is not mentioned in the methodology.
Correct.
And study places not specified.
Correct.
And
okay,
that's
just
it,
a
sir.
minute.
Any other
Niranjan?
point?
Niranjan, is he there?
Yes, sir.
Anything to add, Niranjan, so far?
Nothing, sir. Nothing, sir.
Srikanth, anything to add?
Swaroop is also there, I think. Swaroop has joined. You can ask him for responding.
Swaroop, welcome.
Hi,
Srikanth,
sorry,
anything
sir.
to add?
Study place, is it important?
Allah, it is important. It makes it more transparent.
Okay. No, nothing to add. Everything's right.
Swaroop, so far, what do you
Can I
think?
add a few points in the end, or is it the end of the meeting?
No, it's not the end. It's beginning of the meeting. We have just.
I think I'll add in the end. I think they would have already covered, so I'll wait, and then
Okay.
if they're not, I'll add.
Yeah. Okay. Continue, ma. So, Swarup, just to sum up, what we have basically said so far is that this is one of the landmark trials to look at because rectal cancers, there is already neoadjuvant therapy and everything. But for colon cancers, this is probably the landmark trial.
Definitely.
Correct?
Sir.
Agreed or not?
Definitely agree.
Okay.
Though there are some questions with the methodology, which I will discuss later.
Yeah, sure. Okay. Continue, ma. Nikita.
Yes,
Go to the results.
The results of the study, it was mentioned as the study was done from May 15, 2008 to the December 23, 2016. Patients were recruited during this period. 1,053 patients of 2,591 potentially eligible patients were randomly assigned in 2:1 ratio to neoadjuvant group and to the control group. It was done in 85 centers, 79 in United Kingdom, 3 in Denmark, and 3 in Sweden. This is the number of the cases, respectively. This is a consort diagram summarizing the whole study results.
Okay. So out of the 4,907 patients, eligible were 2,591, and they were 1,053 were randomly assigned because 1,538 patients refused to be part of the trial. Correct?
Yes, sir.
Okay. So 2:1 means number of patients in the neoadjuvant group are 2 compared to 1 in the post-operative chemotherapy group. Correct?
Yes, sir.
No adjuvant plus adjuvant and only adjuvant.
Okay. Quickly summarize the important points in this trial, ma.
Yes, sir. In the neoadjuvant chemotherapy group, neo and post-adjuvant, they have mentioned about the withdrawn patients and also about the post-operative complications, along with the time when they have started the chemotherapy. All of them did not start at the same point. This would be helpful for the subgroup analysis when they had different starting points. And post-operative chemotherapy group, resection attempted in 351 cases. 4 were withdrawn from the group, and one of them did not finish the chemotherapy, and 174 patients finished the chemotherapy. And the 2-year follow-up is also mentioned in the consort diagram.
Okay.
Yes.
Carry on.
Yes. 28%, there was low recurrence rate with neoadjuvant chemotherapy than with the control, with p-value being 0.37, which is significant, and the proportional reductions in the colon cancer specific mortality rate, it was p-value being 0.95, which is not significant. Risk of recurrence was strongly related to histologic regression grade, and 5 years recurrence was 30% for those with no regression, falling progressively to 22% in mild and 13% in moderate, 7% in marked and 0% in complete regression categories. So this is the percentage of complete regression to the no regression, the histological grade of neoadjuvant and control groups, showing the recurrences. As we can see, no regression has the highest recurrence rate. Here again comparing the regression grade with the time of recurrence in the years. This is a 2-year recurrence rate of total neoadjuvant chemotherapy and control groups without any correlation to the regression grade. As you can see, the control group had higher recurrence rate in comparison to the neoadjuvant chemotherapy. These are the intraoperative and post-operative complications in neoadjuvant group and the control group. P-value is insignificant in intraoperative complications, and in post-operative complication, it was significant for pulmonary thromboembolism only. Coming to the discussion, Foxtrot is, to our knowledge, the first phase 3 trial evaluating neoadjuvant chemotherapy in operable colon cancer. The primary objective to detect a reduction in the residual or recurrent disease within 2 years was achieved with a 28% lower event rate than neoadjuvant than adjuvant chemotherapy. Foxtrot results indicate that neoadjuvant chemotherapy than adjuvant may be superior to the conventional post-operative chemotherapy, and it is of less certain benefit in DMMR than PMMR cancer. This is regarding the wild mutation. The Panituzib did not show any significant difference.
No. Don't confuse the issues. See, the thing is, they have said there where the patient has a MMR, that is microsatellite instability, mismatch repair gene deficiency, than the patients who have proficient MMR, which means if there is MMR that is mismatch repair gene deficiency, then in such patients neoadjuvant chemotherapy is less likely to be of benefit compared to those patients who have microsatellite instability and mismatch repair gene, this one, that is MLH1 is HMLH, MSH2, and all of these, they are all the mismatch repair genes. So if they are present, then the neoadjuvant chemotherapy is more beneficial compared to those who have no mismatch repair gene. So that is all it is. I think the other thing you are talking about is the RAS mutation. That is the panitumumab. So that is the RAS mutation where it has been shown that it has not been of much benefit, whether it is given in patients with either the RAS mutation being positive and negative. I think that is a subgroup analysis. So panitumumab is not necessary. That is what they say. And have they defined this histologic regression, Ma? Have they defined it before?
They specifically did not mention in the methodology, sir, but it was taken as pathologic references.
Swarup, can you please come in? See, the thing is, we are not sure whether they have defined the regression. How do they define the regression? Is there any methodology to that?
Yes, sir. There are standardized grades. TRG scoring, tumor regression grading is there. Depending on the amount of fibrosis, amount of necrosis, they have grades.
Okay.
Higher the grade, more the regression. Yes, sir.
Okay.
Highest grade would be pathological complete response.
Okay. Yeah.
Since histologic regression is only prognostic after neoadjuvant chemotherapy, it must be an indicator for chemosensitivity and not simply a surrogate for innately better prognosis tumors. This makes regression grade a potentially useful surrogate endpoint for future trials that might allow a more rapid assessment of novel NAC schedules.
Okay. So you already put up the critique. So explain whatever you said here.
Yes. Pros of the results were that they produced a concert diagram which was very detailed of all the things which had happened from the assessing to the recurrent follow-up. there was a large study population, and there was 2 years is a reasonable follow-up to study about the recurrence, and results had significant p-values, and the subgroup analysis were also done as they have planned. Cons, I'm not sure, sir, whether I could find any cons in the results.
Okay. Srikanth, what do you think of the results?
Yeah, good study. But 28% means they could have stopped in between, no? When it has shown there is so much good results.
Yeah, but I think because it is that is the disadvantage. You can't because you have to look at recurrence, and the significant time to look at recurrence is 2 years. So you can't stop in between. See, if you are looking at major complications that happen.
No, they have done the study from 2008 to 2016. In 8 years, they could have known. They were showing better results. NSS, they could have stopped
and given correct.
Given the new adjuvant to everyone.
Actually, that is why I am not sure some of the methodology, whether how they have actually recruited, and this, that is
28% is very significant. This
correct.
thing.
Swaroop, have you got any more details on, because from 2018 to 16, if they have been recruiting, at the end of maybe 210 or 211, you would have known that NAC is very good compared to adjuvant chemotherapy. Could you have not stopped the trial?
Sir, the statistical power would have been reduced. The number, now we can say retrospectively saying that there are significant, by 2011, the accrual would have been quite lesser. And then
the numbers would have been less.
Yes. Yeah, it wouldn't have shown statistical significance. Yeah, agree. That is the reason. Niranjan, what do you think of the results?
So
2008
the
to
results are good.
2016. Okay.
Yes,
continue.
Niranjan.
Yeah, results are good. My only this thing was I didn't see or I missed. I don't know whether how did they follow up in, like, if suppose there is preoperative neoadjuvant when they have given, was there the total response or not in them also? So what was done? I don't know.
No, surgery was done in all of them.
Is it all of them?
Same surgery
That is
was
what
done for all.
That is what was it necessary? I don't know.
And the surgery is necessary.
Whether they have given. If there was a complete response,
even if there is complete regression.
So the thing is, with the problem is, as of now, even with PET CT, the technology is not good enough to say, for example, if there is complete pathologic response, unless you actually resect the area or the tumor, and then subject it to histology to absolutely define the pathologic complete response. So, for example, it may appear very fibrosed and thickened, but then when you actually subject it to final histology, it may show just fibrosis but no residual tumor. So, but till you actually do the surgery and till you resect it, you will not know that. Swaroop, correct me
that
if
is
I'm
what
wrong.
whether and I agree, sir, with your point. Only thing was in those this thing, how many had complete response even after surgery? How many of them have they given the data? That is what I wanted to know.
Adu data kottilla ansute. I don't think
that is what I didn't see that. I didn't see that anywhere.
That was not the object of the study. The object of the study was recurrence.
No, because recurrence or complete this thing, cure.
No. What basically the study was to look at whether they should give neoadjuvant chemotherapy followed by surgery followed by completion chemotherapy, or you just.
I agree, but if they had given us the data, if they had given us the data, it would have added
post-operatively.
It would have added more value probably if they had given us the data. If there was complete radiological response, and in how many of them there was no tumor at the end of histopathology.
Have they, Nikita, have they given that data?
They did not mention specifically, so they were concentrating more on the recurrence The complete regression number of cases.
They have not said. Yes. They have not said anything about recurrence. Sorry, about
No,
completeness.
and Nikita, I missed whether how did they go for surgery? Did they do any PET CT before going for surgery, or they just gave 6 weeks
No
and they
PET
went
CT.
for surgery?
No,
They
they
No
did.
PET CT or any CT. No CT
nothing.
also.
CT
They did
was
not
done.
def-
No pre surgery, sir. I'm asking.
Pre-surgery CT must have been done, I think, but I think they
That clarity is not there. That's
no clarity is there. Yeah.
They did not ask for any CT, sir, but maybe for surgical purpose they could have done. But they did not mention in the methodology or in the results about the CT before the surgery, sir.
Correct. Swaroop, do you want to come in?
There are some like if a new patient of CA cecum or CA descending colon comes to us, based on this study, we still don't know what to do. Should we give a short course of neoadjuvant chemo, then surgery, then adjuvant chemo? Should we give the entire course of chemo, then surgery? And there was also, this was conceived in an era where the MSI significance was not so well known. Nowadays, if MSI is high, we can start off with dostarlimab or nivolumab, which is known to give complete responses even in stage 4 patients. So with MSI patients already observed this study, but for KRAS mutant and NRAS mutant, these people have, wild type patient, they have used panitumumab. But again, we don't know why they chose to use panitumumab instead of cetuximab, which somehow seems to be slightly better.
They mentioned passing in that cetuximab should have been used, but we had started using panitumumab, something like that. I think they have mentioned that.
Maybe they had sponsored. I think panitumumab makers may have sponsored the trial. That could be one reason. So this only says that neoadjuvant chemotherapy has value, but it does not let us decide how to give neoadjuvant chemotherapy. And we have multiple options even by this study: capox regimen, FOLFOX regimen, full course of FOLFOX followed by surgery, or some amount of chemo followed by surgery followed by adjuvant chemo. In which patient to choose which? This
I
does
think
not answer
that
yet.
is still not very clear. Only thing is, see, the only thing I can think of is that, for example, if you can say that about neoadjuvant chemotherapy also, but you start neoadjuvant chemotherapy, it works on the premise same as the breast cancer, where a tumor of this size will already be a systemic disease, and you are tackling the systemic microemboli and micrometastasis, and so then you make maybe inoperable or partial, inoperable tumors into operable tumors. So that is the advantage of neoadjuvant chemotherapy, and at least you would have sort of killed off a lot of these cells before you operate, so that when you are operating, there is little chance of you causing microembolization of the tumor. So that is the sort of oncologic premise. And the other possible advantage be that in case the patient has any post-operative complication or whatever, and you are unable to give them post-operative chemotherapy, you would have at least given the neoadjuvant chemotherapy, which would have covered it for the majority of the extent. So that may be another thought process that you can think of before you make a decision about whether you should give neoadjuvant chemotherapy or not. Swaroop, what do you say?
Yes, since you spoke about breast cancer, sir, I think these people have missed out on a very valuable opportunity. In breast cancer neoadjuvant trials, we always include, as part of long-term follow-up, local recurrence rates, distant relapse rates. They see that neoadjuvant chemotherapy reduces local recurrences and distant relapses. Like as you said, neoadjuvant chemotherapy would also take care of systemic disease. So they should have done that analysis about how neoadjuvant chemotherapy would reduce the rate of distant relapses and local relapses or regional relapses.
Yeah. Maybe they will say, further results may come.
With longer term follow-up, they'll be able to use mature data.
Because as you said, the recruitment has been slow. So maybe they may not have the final data for the 5-year data for the patients who've been recruited fairly late.
This study is going to inspire a lot of neoadjuvant studies for colon cancer. So
Yeah,
that is
I
for
think
guarantee.
definitely that is the spell.
Yes, sir.
Nikita, what else have you got? You stopped there, yeah. So this is collateral studies, is it? Nikita?
Rectal, I think it's already there.
Yeah.
This is about colorectal.
Nikita?
So we need to see more of colon.
This particular trial has used neoadjuvant chemotherapy in somebody who already has acute obstruction. It's a dangerous thing to do. Obstructed patients may already be in sepsis, and we give chemo, they will become
perforate also.
fall down. Yes, very dangerous to do this retrospective study, which this is here. Chinese study.
Yeah. Nikita, you're not speaking. Hello? Nikita, are you there?
Maybe network is down.
She's just putting it up, but she's not talking.
I'm sorry, sir. It was muted. I'm sorry, sir.
Okay.
I was speaking, but it was muted. Okay.
So tell us about this.
This is a retrospective study which is about the neoadjuvant chemotherapy for left-sided malignant colorectal obstruction, sir. They had insignificant results which showed that it did not improve the one-year recurrence or free survival rate, sir.
How can anyone go neoadjuvant chemotherapy in obstruction?
Yeah.
That acute.
Nikita, if you are given a chance, what would you do in an obstructing left-sided colorectal cancer?
I would take for the surgery, sir, immediately. I mean,
but
as
if
a
all
primary,
facilities are available, what would you do? Patient is not very well. He's dehydrated. He's obstructed, nutritionally not good. He's come to you. What will you do? You have everything on earth. Patient can afford everything that you can offer him. You stent them, ma. You give.
We had discussed just last week, I think.
You stent them, give it a week or so, improve their nutrition, obstruction is relieved, and patient is able to pass, and the colon is clear now, and you have corrected the electrolyte and other imbalances. Patient is better. Then you take them for surgery. So, or if you cannot do, if you have no access to stent, you can do a colostomy or something, and then wait for some time and do operate. Or if the patient gets better in 24 hours, then you can do the resection and give them a stoma, which is Hartmann's procedure, or you can anastomose and give them a what do you call that, ileostomy or a colostomy before the anastomosis. So these are, anyway, that is just a different question. But I don't think you can even think about chemo, as Swarup said. You can't think of chemo, you will kill them off. So you shouldn't do these things. It is dangerous.
Only if you're stented and if obstruction is relieved. Or colostomy.
Yeah, correct.
Whether they have done any diversion before this thing, neoadjuvant?
No, sir, they did not mention about it. So directly they were giving a neoadjuvant chemotherapy and comparing with the surgery teams.
But with the left-sided malignancy, can it go for acute obstruction?
Yeah, it is usually
left-sided is more prone for obstruction.
No, more prone for obstruction, but gradual altered bowel habits will be there, no, before they go for
I know, but I think by the time they have said here very clearly colonic obstruction. So they have said it is obstruction.
Yes.
Any other papers, ma?
One more paper, sir.
What is the result of this, sir?
Results were insignificant. Sir.
It did not respond.
No.
Neoadjuvant therapy in locally advanced colon cancer, a meta-analysis and systemic review. It is also a Chinese study. The 5 eligible randomized trials. Sorry, sir. 5 eligible randomized trials and 2 observational studies, including 29,500 patients were considered, and overall survival had showed a significant p-value, and disease-free survival did not show significant, also showed significant p-value.
So which means that.
So this is also a supportive evidence for neoadjuvant therapy, sir.
I think as I think Swaroop very clearly, succinctly summarized it by saying, still the question as which group of patients will you consider giving neoadjuvant chemotherapy, and what neoadjuvant chemotherapy will you give, and how long will you give it, when will you opt for surgery, and post-operatively which are the patients you would have to restart the chemotherapy, complete it, and in which patients do you give only adjuvant chemotherapy. So these questions are still unanswered, though there is a sort of trend showing that neoadjuvant chemotherapy is better. So you will have to redefine. I think more results have to come. I think probably the more studies are already underway, which will tell us maybe which are the subgroup of patients where you consider giving neoadjuvant, which are the subgroup of patients where you will operate straight away. And I think the importance of microsatellite instability has now come to fore. So what do you do with them? All of these things, questions will be clarified later. Swaroop, what is your take?
So this is an incremental step in the management of colon cancers. And as you already mentioned, more studies will come and answer the final points. And for MSI stable patients, unstable patients, KRAS mutant and non-mutant patients. And among patients with BRAF mutations, there are already BRAF inhibitors which are being experimented in the metastatic setting, which may also come into the neoadjuvant setting later if they are found successful. It will keep evolving and we'll have to keep pace with it.
Okay. Niranjan, final thoughts?
Sir, I agree with your comments that probably more and more neoadjuvant chemotherapy trends are setting in. Even for rectal, I think it's almost now neoadjuvant radio and chemo. Even for probably operable cancers also, like locally advanced. So probably for colon also, that the only thing is the criteria has to be defined. Exactly where to give neoadjuvant and where to operate.
Srikanth, your comments?
Yeah, good paper. I think that will be the trend, neoadjuvant.
Sania, what is your comment? How do you think she presented?
So
Presentation was good.
It was good.
Appreciate.
Yes, sir.
Good presentation, madam.
Thank you, sir.
But when
Sania,
you're asking mature results, as what were you people doing all these days when you didn't ask Ravishankar?
Sir,
when you have got any doubts, you should ask the teachers, no? You should not ask here.
Sania.
Any doubts you should clear before presenting.
Yes, sir.
I think
sir,
yes, Sania, tell me.
Yes, sir, your final comments. Okay, I was telling she presented well, sir. And it is a good study also that's taken, but.
So I think, final comments from me. Thank you, all of you, for active participation. This is a new area because so far, as Niranjan said very clearly, rectal cancer is fairly well established in terms of the neoadjuvant chemo radiation. Colon cancers, this is the first paper of a large, high quality randomized control trial which has addressed this question. And probably the knowledge as far as chemotherapy and then the genetics and then the advances in even the histologic grading and histologic reporting has come on leaps and bounds even from 2008 to 2023 now. So I think this is a field which is very rapidly progressing and evolving. So I think subgroup data will come in, which will then help us to stratify these patients into giving them neoadjuvant or operating straight away and then going for chemotherapy post-operatively. So I think, but one thing is for sure, neoadjuvant chemotherapy for colon cancer has come in a big way and is here to stay. Definitely very beneficial in a significant group of patients. So you have to identify which are the subgroup which may not benefit from neoadjuvant and then go for surgery in such patients. I think that will be the more interesting answer. And I think Nikitha has presented it well. And it is a very good paper from an extremely high impact factor, high SFJ factor journal. So it is a very good paper to have discussed, RCT. Thank you everybody for a good discussion. Good night.
Thank you.
Thank you, sir.
Swaroop, thank you.